Welcome to the Epidemiology and Prevention of Vaccine Preventable Diseases webinar series, also known as the Pink Book. I'm Dr. Raymond Strickus from the Immunization Services Division at the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention in Atlanta, Georgia. And I welcome you to today's program. All you need to participate today is an internet connection, which carries both the visual and the audio input and output. The learning objectives for today's program are to describe the different forms of immunity, describe the different types of vaccines. For each vaccine-preventable disease, identify those for whom routine immunization is recommended. For each vaccine-preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice. And lastly, implement disease detection and prevention healthcare services such as smoking cessation, weight reduction, diabetes screening, blood pressure screening, or immunization services most relevant to this program to prevent health problems and maintain health. Today's agenda on the Epidemiology and Prevention of Vaccine Preventable Diseases webinar series, that is Pink Book, is pneumococcal disease and vaccines, presented by our medical officer, Dr. Andrew Kroger, from the Communications Education Branch, Immunization Services Division, NCIRD at the Centers for Disease Control and Prevention. Continuing education information for right now, you should know that for CE credit, you should go to http://www.cdc.gov/TCEONLINE, that's TCE online. For this live course presented today, the CE credit expires October 24th, 2016. For the Enduring Archive course, that is credit for this course if you engage it on the internet later on. CE credit will expire June 1st of 2018. When obtaining CE, you'll be required to provide a verification code. Please watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources for this program, pneumococcal disease and vaccines, will be available at https://www.cdc.gov/vaccines/pinkbook/pb15.asp. If you have a question, please enter your question in the Q&A pod you'll see on your screen. We'll summarize those questions and try to answer as many as we can today during the program. And for those we cannot answer, we'll get those answers posted on our website in writing. Let me now turn the microphone and the slide.
Thank you, Dr. Strickus. It is a pleasure to present to you today from Atlanta. Today I'll discuss pneumococcal disease and pneumococcal vaccines. The flow of my presentation will correspond to the chapter entitled Pneumococcal Disease on page 279 of the Pink Book. The slides that I'm using are similar to the graphics you see in the margins of the Pink Book, and I will be posting these slides in the near future. Pneumococcal disease is caused by Streptococcus pneumoniae bacteria, which are lancet-shaped, gram-positive, facultative anaerobic organisms. They are typically observed in pairs, but may also occur singularly or in short chains. There are 92 known serotypes. Some pneumococci are encapsulated, their surface is composed of complex polysaccharides. The polysaccharide capsule is an important virulence factor, which means that encapsulated organisms can be deadly for humans and experimental animals, whereas organisms without capsular polysaccarides are not. Capsular polysaccharides are the primary basis for the pathogenicity of the organism. They are antigenic and form the basis for classifying pneumococci by serotypes. The type-specific antibody to capsular polysaccharide is protective. The antibodies and complement interact to opsonize the pneumococci, which facilitates phagocytosis and clearance of the organism belonging to the same serotype. Antibodies to some pneumococci capsular polysaccharides may cross-react with related serotypes as well as with other bacteria, providing protection against these organisms. Most strep pneumoniae serotypes have been shown to cause serious disease, but only a few serotypes produce the majority of pneumococcal infections. The 10 most common serotypes are estimated to account for about 62% of invasive disease worldwide. The ranking and serotype prevalence differ by patient age group and geographic area. In the United States, prior to widespread use of the 7-valent pneumococcal conjugate vaccine, the 7 most common serotypes isolated from blood or cerebrospinal fluid, CSF, of children younger than 6 years of age accounted for 80% of the infections. These 7 serotypes account for only about 50% of isolates from older children and adults. Pneumococcal disease is the second most common cause of vaccine-preventable death in the U.S., causing over 5,000 preventable deaths every year. Pneumococcal pneumonia is the most common clinical presentation of pneumococcal disease among adults, although we don't consider pneumonia alone invasive disease. The incubation period of pneumococcal pneumonia is short, about 1 to 3 days. Symptoms generally include an abrupt onset of fever and chills or rigors. Typically, there is a single rigor and repeated shaking chills are uncommon. Other common symptoms include pleuritic chest pain, cough productive of mucopurulent rusty sputum, dyspnea, which is shortness of breath, tachypnea, which is rapid breathing, hypoxia is poor oxygenation, tachycardia is a rapid heart rate, malaise, and weakness. Nausea, vomiting, and headache occur less frequently. Other clinical symptoms include the 2 most common forms of invasive disease, that's bacteremia and meningitis. Bacteremia is bloodstream infection, and meningitis is infection of the meninges, which is the lining covering the brain and the CSF. The clinical symptoms, CSF profile, and neurologic complications of pneumococcal meningitis are similar to other forms of purulent bacterial meningitis. Symptoms may include headache, lethargy, vomiting, irritability, fever, nuchal rigidity, cranial nerve signs, seizures, and coma. This graph of invasive pneumococcal disease shows the rate of invasive disease per 100,000 population by age group and demonstrates that the highest rates of invasive disease occur in those younger than 2 years of age and those 65 years of age and older. These data are generated by the Active Bacterial Core Surveillance System, or ABC's data, and highlight age as a very important risk factor for invasive disease. There are also medical risk factors for invasive disease. These include functional or anatomic asplenia. Functional asplenia includes sickle cell disease because children with sickle cell disease slowly destroy their own spleen. Altered immunocompetence is also a risk factor for invasive disease, as well as other underlying medical conditions like chronic renal disease, nephrotic syndrome, and conditions that predispose to CSF leak. Other underlying medical conditions are risk factors for invasive disease. The risk is lower for these conditions. They include things like chronic heart disease, chronic lung disease, diabetes, alcoholism, chronic liver disease, and solid organ transplant. There are also some behavioral risk factors that can predispose to invasive disease, thought to be mediated by effects on the immune system. This has been observed in cigarette smokers 19 years of age and older, and also patients with cochlear implants have an increased risk of pneumococcal meningitis. There are some other non-medical risk factors not mentioned on this slide for invasive disease. They include child care attendants and also Alaska Native and certain American Indian groups, Navajo, White Mountain Apache, as well as African Americans. The reservoir for pneumococcal disease are human carriers. Pneumococci are common inhabitants of the respiratory tract. They may be isolated from the nasopharynx of 5 to 90% of healthy adults. Rates of asymptomatic carriage can vary with age, environment, and the presence of upper respiratory infections, which really explains that wide range. Only 5 to 10% of adults without children are carriers. On military installations, as many as 50 to 60% of service personnel may be carriers. The duration of carriage also can vary. It's generally longer in children than in adults. The relationship of carriage to the development of natural immunity is poorly understood. Transmission of strep pneumoniae occurs as the result of direct person-to-person contact via respiratory droplets and by autoinoculation in persons carrying the bacteria in their upper respiratory tract. Pneumococcal infections are more common during the winter and in early spring when respiratory diseases are more prevalent. The period of communicability for pneumococcal disease is unknown, but presumably transmission can occur as long as the organism appears in respiratory secretions. Now I'd like to talk about the pneumococcal vaccines. These vaccines are composed of pneumococcal polysaccharide. The first vaccines licensed were considered pure polysaccharide vaccines. The first contained polysaccharide from 14 different types of pneumococcus and was licensed in 1977. In 1983, a 23-valent polysaccharide vaccine was licensed and replaced the 14-valent vaccine. In 2000, the first pneumococcal conjugate vaccine was licensed, which consists of polysaccharide from 7 types of pneumococcus conjugated to a protein. In 2010, an expanded 13-valent conjugate vaccine replaced the 7 serotype conjugate vaccine. The pneumococcal polysaccharide vaccine, or PPSV23, contains polysaccharide antigen from 23 types. These types cause 60 to 76% of invasive disease generally. However, this vaccine is not effective in children younger than 2 years of age because it does not generate lasting immune memory. It also has not been demonstrated to provide protection against pneumococcal pneumonia. For this reason, providers should avoid referring to PPSV23 as a pneumonia vaccine. The pneumococcal conjugate vaccine, or PCV13, contains 13 serotypes, 7 of which were also in PCV7. Those are 4, 6B, 9V, 14, 18C, 19F, and 23F. And so the 13-valent vaccine contains 6 additional serotypes, namely 1, 3, 5, 6A, 7F, and 19A. These serotypes are conjugated to a non-toxic diphtheria cross-reactive material 197 carrier protein. The vaccine does contain 1 serotype, which is type 6A, that is not in the PPSV23. Importantly, because this is a conjugate vaccine, it generates a long-lasting immune response useful in children as well as adults. It was approved by the FDA based on demonstration of immunologic non-inferiority to PCV7 rather than clinical efficacy. PCV7 was introduced into the routine schedule in 2000 and has been tremendously successful in reducing the rate of invasive pneumococcal disease, or IPD. Between 1998 and 2009, PCV7 reduced rates of PCV7 type invasive disease, along with serotype 6A, by 99%, and reduced rates of invasive disease caused by all serotypes by 76%. By 2008, 61% of invasive pneumococcal disease cases among children younger than 5 years of age were attributable to the serotypes in PCV13, and those types contained in PCV7 now only accounted for 2% of the cases. The remainder were accounted for by the additional 6 serotypes, and serotype 19A accounted for 43% of the cases. In 2013, 20 to 25% of invasive pneumococcal disease cases among adults 65 years old and older were attributable to the PCV13 serotypes. PCV13 serotypes accounted for 10% of community-acquired pneumonia cases in adults, and this included pneumonias that had no associated bacteremia. You may wonder how it's possible to identify a specific serotype of Streptococcus pneumoniae in patients that have only pneumonia diagnosed by X-ray or even maybe clinically with no organism obtained from the blood. The manufacturer of PCV13, Pfizer, was able to determine type-specific non-bacteremic pneumonia cases with the use of a urinary antigen test based on an immunochromatographic membrane technique. So the top of this slide describes the percent reduction in cases among adults 65 years of age and older, both in the years 2015 and predicted by 2019. The data listed below this first row highlights the number of cases of various outcomes prevented, also corresponding to those 2 years. Now, the number of cases preventable will decrease over time. Because the use of PCV13 in children is actually preventing disease in adults as well. This is defined in the slide as herd effects in that top row. The top middle cell describes how much of the reduction in adult disease is due to the vaccination of children. So for the year 2015, this herd effect or community immunity will account for about 20% of the effect. However, by 2019, it will account for 86% of the effect, meaning the direct effect of the vaccine will be much less by 2019. There still will be significant reduction of disease in 2019. If you look in the right-hand column on the lower part of the slide, for PCV13 in adults by the year 2019, the vaccine will prevent 80 cases of invasive pneumococcal disease, 1,070 cases of inpatient community-acquired pneumonia, and 1,560 cases of outpatient community-acquired pneumonia. And this is in adults 65 years old or older. So, having discussed the burden of disease, I'll move on to talk about immunogenicity and effectiveness, beginning with PPSV23 vaccine. While 80% of healthy adults who receive PPSV23 vaccine develop antibody against the serotypes contained in the vaccine, most of the estimates of effectiveness range between 60 to 70% against invasive disease among immunocompetent older persons and adults with underlying illnesses. Effectiveness among immunocompromised or very old persons is not demonstrated. The confidence intervals become very wide in most studies looking at adults 40 years old or older, with some effectiveness estimates as low as 10%. And as I've already mentioned, this vaccine is not thought to prevent pneumococcal pneumonia. Pneumococcal conjugate vaccine is highly immunogenic in infants and young children, including those with high-risk medical conditions. The efficacy of PCV7 was 97% for prevention of invasive disease caused by vaccine serotypes. Furthermore, children who had received PCV7 had 7% fewer episodes of acute otitis media and underwent 20% fewer tympanostomy tube placements than did unvaccinated children. PCV13 was licensed in the United States based upon studies that compared the serologic response of children who received PCV13 to those who received PCV7. The studies showed that PCV13 induced levels of antibodies that were comparable to those induced by PCV7 and shown to be protective against invasive disease. Furthermore, in another study of PCV13, children 7 through 11 months, 12 through 23 months, and 24 through 71 months of age who had not received pneumococcal conjugate vaccine doses previously were administered 1, 2, or 3 doses of PCV13 according to the age-appropriate immunization schedules that existed for PCV7. This was, essentially a bridging effort to look at those reduced dose number complete series of PCV7. And the schedules essentially did result in antibody responses to each of the 13 serotypes, which were comparable to those achieved after the 3-dose infant PCV13 series. This was for all serotypes, except for serotype 1, IgG antibody levels were slightly lower among children aged 24 to 71 months of age. But for all of the others, it was comparable with those reduced dose complete series schedules. A randomized placebo-controlled trial, the CAPITA trial, was conducted in the Netherlands among approximately 85,000 adults 65 years old or older during 2008 through 2013. This was to evaluate the clinical benefit of PCV13 in the prevention of pneumococcal pneumonia. PCV13 first developed 75% efficacy against vaccine-type invasive pneumococcal disease and 45% efficacy against PCV13 serotype non-bacteremic pneumonia. Now I will discuss the recommendations for the use of these two pneumococcal vaccines. The PCV13 recommendations, as well as the PPSV23 recommendations for infants and children, were published in the MMWR on December 10th, 2010. I will begin with PCV13 vaccine. A note on the complexity of recommendations for PCV13. PCV13 is approved by the Food and Drug Administration for children 6 weeks through 17 years of age and for adults 50 years of age and older. But ACIP's recommendations and CDC's guidance do not match the package insert. Beyond the routine infant-toddler recommendation, which we will discuss shortly, ACIP recommended use of PCV13 for all immunocompromised persons 6 years of age and older in 2012 and 2013. So that involved usage between 18 years of age and 49 years of age, which is not in the package insert. And ACIP recommended use of PCV13 for all adults in 2014. Which was covered by the approval from FDA. So let me begin with PCV13 now in children. Our routine recommendations for use go all the way back to 2010 and pretty much match the original recommendations for PCV7 with a few differences. Routine recommendations for PCV13 are the same as PCV7 for children 2 months through 59 months of age. Vaccination should be administered as a 4-dose series at 2 months, 4 months, 6 months, and 12 to 15 months of age. Fewer doses are needed to complete the series if the series is started at 7 months of age or older. The number of doses depends on the child's current age and the age at which the first dose was given. Children who have received 1 or more doses of PCV7 can have those doses count, but they should be completing immunization series with PCV13. Here is the routine catch-up schedule for unvaccinated older children, and by that we mean older than 7 months. It is derived from Table 8 in the 2010 pneumococcal recommendations for infants and toddlers. These are children who begin the series with PCV13, but they begin the series late. If the age at the first dose is between 7 and 11 months of age, a primary series of 2 doses should be administered with 4 weeks in between, followed by a booster dose after 12 months of age, and that booster should be 8 weeks later. If the PCV13 series is begun at 12 to 23 months, then 2 doses are recommended, separated by 8 weeks. The series is begun between 24 and 59 months of age and the child is considered healthy, then only 1 dose of vaccine is necessary. However, if the child has an underlying medical condition and begins the series between 24 and 71 months of age, then 2 doses are recommended with 8 weeks between the doses. These underlying medical conditions that are mentioned here include chronic heart disease, chronic lung disease, diabetes, CSF leak, cochlear implant, sickle cell disease, other hemoglobinopathies, functional or anatomic asplenia, HIV infection, and immunocompromising conditions, and I'll lump in renal disease with immunocompromising conditions here. So this is an important table that should be used along with Table 9 in the 2010 document when determining whether high-risk children 24 through 71 months of age have either a complete schedule or an incomplete schedule. It can sometimes be very complicated to determine this without having these tables from the 2010 recommendations. There are also recommendations for catch-up in children who have received a complete series of PCV7. A single supplemental dose of PCV13 is recommended for all children 14 through 59 months of age who have received 4 doses of PCV7 or another age-appropriate complete PCV7 schedule. For children who have an underlying medical condition, a single supplemental PCV13 dose is recommended through 71 months of age. And this is inclusive of children who may have received PPSV23 previously as well. Now, PCV13 should be administered at least 8 weeks after the most recent dose of PCV7 or PPSV23, and this will constitute the final dose of PCV for these children. Now, this recommendation is already obsolete with respect to having 4 complete doses of PCV7 for healthy children. It's not possible, they've all aged out, so that's really not possible anymore to have a complete 4-dose PCV7 schedule. By December of 2016, this recommendation will be obsolete for high-risk children. They also will not have been able to receive 4 doses, a complete schedule of PCV7, because of the date of the expiration of this vaccine. It doesn't exist anymore and could not have been given in 4 doses in the past. There also are recommendations for children who have received a lapsed schedule of PCV7. It's slightly different from the catch-up schedule in lapsed children who begin the series with PCV13. Children 24 through 71 months of age with underlying medical conditions who received an incomplete schedule of PCV7 should receive 2 doses of PCV13 8 weeks apart. This is another recommendation that is not going to be needed soon based on the past expiration of PCV7. In fact, it's not possible to have received a 3-dose series of PCV7 by the time April of 2017 rolls around. And then by June of 2017, it will not have been possible to have ever received a 2-dose series of PCV7 and still be young enough to require protection with pneumococcal conjugate vaccine, even in high risk. A single dose of PCV13 should be administered to children 6 through 18 years of age who have not received PCV13 previously and are at increased risk for invasive pneumococcal disease because of the following conditions: anatomic or functional asplenia, which includes sickle cell disease, immunocompromising conditions inclusive of renal disease, and HIV infection, cochlear implant, or CSF leaks. And this recommendation is regardless of previous history of PCV7 or PPSV23 vaccine. Or I don't think 14 vaccine, it's still possible. That one, we replaced in 83. Now I'd like to discuss PCV13 use in adults. PCV13 was licensed for use among adults 50 years old or older on December 30th, 2011. FDA approved this use under an accelerated approval pathway, and it was based on serologic studies that compared the response of PCV13 recipients to a response of PPSV23 recipients. One of the post-approval conditions of licensure was the performance in that randomized controlled trial I mentioned of PCV13 against pneumococcal pneumonia. among adults 65 years old and older. This was the trial in the Netherlands, the community-acquired pneumonia immunization trial in adults, or the CAPITA trial. And I already mentioned it was 45% effective against non-bacteremic pneumonia and 75% effective against invasive disease. Because of these results, ACIP now recommends a dose of PCV13 in all adults 65 years of age and older if they have not already received a dose of PCV13. This graph shows the incidence of invasive pneumococcal disease, IPD, in adults ages 18 through 64 years who are healthy compared to those with selected underlying conditions. Note cases of IPD per 100,000 persons are shown on the vertical axis, and various medical conditions are listed on the horizontal axis. The two columns on the right of the graph demonstrate that individuals with hematological cancers and HIV/AIDS have more than a 20-fold increased rate of IPD compared to persons without these conditions. Adults with other conditions on this graph have a 3 to 7-fold increased risk for IPD compared to persons without these conditions. Because of this, we recommend that adults 19 years of age and older with one of these risk factors should receive a dose of PCV13. And those are immunocompromising conditions, inclusive of renal disease, functional or anatomic asplenia, CSF leaks, and cochlear implants. Note that in many cases, both PCV13 and PPSV23 will be recommended. A dose of PCV13 should be administered first, followed by a dose of PPSV23 at least 8 weeks later. Adults with one of these conditions will then be recommended for a second dose of PPSV23 5 years later. I'm going to talk about use of these two vaccines together. I don't want to get ahead of myself, so before I do that, I want to discuss the use of PPSV23 vaccine. And I need to do this in both children and adults. So pneumococcal polysaccharide vaccine is recommended for persons 2 years old and older with a normal immune system or immunocompetent who have chronic illnesses like the ones listed on this block, heart disease, cardiovascular, pulmonary disease, which is inclusive of asthma if 19 years old or older, diabetes, liver disease, alcoholism. It includes cigarette smoking if 19 years of age or older, as well as patients with CSF leak or cochlear implants. Pneumococcal polysaccharide vaccine also should be considered for persons in environments or settings with increased risk for pneumococcal disease or its complications, such as certain Alaska Native or American Indian populations. Pneumococcal polysaccharide vaccine is also recommended for persons 2 years old and older who are immunocompromised either due to disease or immunosuppressive drugs, asplenia, functional or anatomic, chronic renal failure, nephrotic syndrome, Hodgkin's disease, lymphoma, leukemia, multiple myeloma, organ transplant, and HIV infection, or really any condition that is considered immunocompromising. So they're recommended for PPSV23 as well as PCV13. Routine revaccination with PPSV23 vaccine is not recommended for patients with the high-risk conditions that are grouped under immunocompetent conditions, nor with CSF leak and cochlear implants. However, a revaccination dose is recommended for persons 2 through 64 years of age who are at the highest risk of pneumococcal infection. So this includes first of all, the interval for this revaccination dose is a 5-year interval and no shorter than this between the two doses. And this is recommended for functional or anatomic asplenia, including sickle cell disease, immunosuppression, which includes HIV infection, transplant, chronic renal failure, and nephrotic syndrome. Once someone turns 65 years of age, a dose of PPSV23 is recommended for everyone, and regardless of previous doses of PPSV23 given before the 65th birthday, but only one and only one dose is recommended after the 65th birthday. So now that I've discussed vaccination recommendations individually for PCV13 and PPSV23, I'd like to discuss how to use these two vaccines together. And these recommendations are, again, based on CDC's guidance for the use of the vaccines. First, PCV13 and PPSV23 should not be administered during the same clinic visit. Either of these vaccines can be administered simultaneously with influenza vaccine, a completely different vaccine, as well as most other routinely recommended vaccines. But do not give PCV13 and PPSV23 together. We want you to administer PCV13 before PPSV23. In children, this will mean finishing the series of PCV13, waiting 8 weeks, and then administering in those children that are indicated for PPSV23, either 1 or 2 doses of PPSV23. And again, 1 or 2 depends on which risk condition the child has. Vaccination of adults is a little more complicated. I'll go through some details, but I do want to first share this web page at the URL that you see listed here. This page has a table that lists what the indications are and how various indications affect the decision to use PCV13, PPSV23, or both. There are additional pages at this URL that goes through exactly the timing, order for various age groups and risk conditions for these two vaccines. So it's a very, very useful website, and I highly recommend you look at these pages. They don't translate really well to a PowerPoint presentation, so I'm going to kind of go through some of these details using a slightly different schematic. I'd like to first discuss use of the two vaccines for adults 19 through 64 years of age that have immunocompromising conditions. By this, these are the risk groups that include asplenia, sickle cell disease, renal disease, CSF leaks, cochlear implants, and other forms of immunocompromise. So a dose of PCV13 is recommended first, followed by the first dose of PPSV23, which should be at a minimum of 8 weeks of age. Now, this 8-week interval exists to reduce the risk of mild reactions when doses of these two vaccines are administered at too short an interval. After the dose of PPSV23, a second dose of PPSV23 will be recommended 5 years later for a subgroup of adults with asplenia, renal disease, and immunocompromising conditions. It excludes CSF leak or cochlear implant. If the 2 doses of PPSV23 are recommended, the interval is 5 years. The 5-year interval between 2 doses of PPSV23 is obviously it's wider than that interval I mentioned, but of 8 weeks between the 2 different vaccines. The rationale is the same: to reduce the risk for local reactions, mostly mild but sometimes severe. PPSV23 is known as a reactogenic vaccine, so we want this 5-year interval between the 2 doses. And then note that a dose of PPSV23 is recommended for all persons after the 65th birthday. Looking at the same group of individuals, what if PPSV23 has already been administered? Data shows that the optimal response from the PCV13 vaccine, which is going to be recommended, requires separation and following a dose of PPSV23 by at least a year. Why is that? A dose of PPSV23 given first generates a set point for the immune response, a level of antibodies beyond which it is really not possible to boost antibody levels even higher. The effect is thought to last for at least a year, so ACIP made a recommendation that PCV13 should be administered first when possible, but in circumstances where it's not administered first, regardless of risk factors that exist, the dose of PCV13 should wait an entire year after the dose of PPSV23. That's to optimize the immune response to PCV13. So that's the first interval you see on this slide, 1 year. Now, a second dose of PPSV23 is recommended in this high-risk immunosuppressed group. The dose has to be spaced 8 weeks from the dose of PCV13, but also 5 years from the first dose of PPSV23. Remember, this is not inclusive of CSF leak or cochlear implant patients, the second dose of PPSV23. Finally, like in every scenario, a dose of PPSV23 is recommended after the 65th birthday. This will be the only dose given after the 65th birthday. Our new recommendations from 2014 highlight routine recommendations for the use of PCV13 in all adults 65 years of age or older. This recommendation is only for PCV13 vaccine-naive adults. So no dose of PCV13 if a dose has already been administered prior to the 65th birthday. Also, a dose of PPSV23 will be recommended after the 65th birthday. And of course, the reason for this is a substantial portion of invasive disease in adults 65 years of age and older is caused by non-PCV13 types. It's a 23-valent vaccine as opposed to a 13-valent vaccine. But for the reasons I've mentioned previously, PCV13 needs to be given first. In the healthy adult, the recommended interval between this first dose of PCV13 and PPSV23 is 12 months. This is a programmatically derived interval. It's based on the feasibility of scheduling 2 visits for this vaccine and the need to have them separated by 12 months in order to be reimbursed by Medicare. So we want PPSV23 to be given 12 months later. It can be later than 12 months. It can be given, but 12 months is our recommendation. If an adult is high risk and immunocompromised and is 65 years of age and older, if they have no prior history of pneumococcal vaccination, the interval between the dose of PCV13 administered first and PPSV23 should be 8 weeks. There will be healthy adults 65 years of age and older that may have received a dose of PPSV23 at an earlier point in time. In many circumstances, that would be a vaccine error, but if it's happened in the past, it happened. And so what do you do in this circumstance? So note there are 2 rows on this slide. The top row indicates a previously administered dose of PPSV23 before the 65th, or I'm sorry, after the 65th birthday, and the bottom row represents a dose of PPSV23 given previously before the 65th birthday. So look at the top row first. If PPSV23 is given first and after the 65th birthday in a healthy adult, PCV13 has to wait a year after PPSV23. The dose of PPSV23 has been given before the 65th birthday. We still want a year to pass. We need that optimized vaccine response. Actually, the 65th birthday should pass as well. And then a dose of PCV13 can be given, followed by this recommended dose of PPSV23, which must be given after the 65th birthday. That dose should be given 12 months after the dose of PCV13. And also should be given a 5-year interval from the prior dose of PPSV23. What about an adult 65 years of age and older that received a dose of PPSV23 after the 65th birthday and is high-risk immunocompromised? Well, our 1-year interval is necessary between PPSV23 and PCV13. We still need to optimize the immune response. It's challenging to hold off given PCV13, but we want you to do that to get a maximal response. The dose of PPSV, so if it's given PPSV23 given first, wait a year, and then give PCV13. Note that on the bottom row, if PPSV23 was given before the 65th birthday, it may have been a year by the time that the patient turns 65. If not, it still has to wait a year, but give PCV13 after the 65th birthday, and then PPSV23 can follow that dose of PCV13 by 8 weeks. Before I move away from this topic, I want to acknowledge how complicated all of this is and to share some new information regarding use of these vaccines. It may provide your aching brain some relief, but it's important that I share it because it's essentially kind of new policy which will be coming out soon in the Pink Book supplement. I've discussed ad nauseum the required minimum intervals between all of these doses of vaccines. But in some cases, when you violate these minimum intervals, we want you to try to keep them. But if they happen to be violated, we don't recommend repeating either dose. This applies to really any concomitant PCV13, PPSV23 administration in children or adults, both simultaneous and interval violations. It applies to violations of the minimum interval between 2 doses of PPSV23 doses in adults. What I'm getting at is you do not have to repeat these doses. Try to use the minimum intervals, but if a mistake happens, you don't have to repeat them. I will make the point that between 2 doses of PCV13 in children, the old rules will apply. If you violate the minimum interval, you do have to repeat the dose. The last topic I'm going to address are contraindications and precautions for pneumococcal vaccines. These are fairly straightforward. The only contraindication to both of these vaccines is a severe allergic reaction to a vaccine component or following a prior dose of vaccine. The only precaution is a moderate or severe acute illness. Adverse reactions do occur with these vaccines. Local reactions occur in 30 to 50% of doses of PPSV23. With PPSV23, rates of fever and myalgia are less than 1%, and severe adverse reactions are rare. For PCV, local reactions rates are similar to PPSV23. The rate of fever is slightly higher. Febrile seizures, while rare, they occur in only 1 to 14 out of 100,000 doses. They have a slightly higher rate when PCV is administered concomitantly with influenza vaccine. If both vaccines are administered simultaneously, the rate of febrile seizures rises to a range of 4 to 45 out of 100,000 doses. So there's a slightly increased risk. Severe adverse local reactions occur in 8% of vaccinees. I will note that the grading and the label of severe included tenderness that affects limb movement. The next few slides that I have are reference pages. Listed on the first few slides are ACIP statements that have come out. They're kind of in separate documents with separate URLs, so I wanted to make sure they were all listed here. These documents span both children and adults and include information about both PCV13 and PPSV23. We also have on this reference page the Pink Book chapter on pneumococcal disease, as well as a link to the important handout on the pneumococcal website, which highlights how to use both PCV13 and PPSV23, along with the corresponding intervals between these doses. And lastly, the web page for the active bacterial core surveillance system is listed here. And so with that, I will turn the mic back over to Dr. Strikas.
Thank you very much, Kroger. Let me now give you continuing education information for this program, which you can use, as we described earlier, CE credit will expire for today's live program, October 24, 2016. The course code for today's program is WC2645-092116, the latter part being today's date. Again, that's WC2645-092116. The verification code is PNEUMO, capital PNEUMO-16. And again, CE credit expires for the live program October 24th, 2016. Instructions about the CE information is available in the resource pod. So let us now go and try to address as many of your questions as we can. Dr. Kroger, the package insert for pneumococcal conjugate vaccine suggests the antibody response for some serotypes of that vaccine and possibly some subtypes of influenza are lower if the two vaccines are given simultaneously. What should we do if both are recommended? Can they be given at the same time?
Yes, they can be administered simultaneously and should be administered simultaneously if they both are recommended. The antibody response to all serotypes of PCV13 actually was not lower in a subgroup of the patients that were studied, those 65 years old and older. And for the patients younger than 65 years of age, even though there were reduced antibody levels seen in 3 of the 13 serotypes, if a patient is recommended for both vaccines and they're younger than 65 years of age, and specifically for PCV13, that means they're at high risk for invasive pneumococcal disease, and they need to be vaccinated, and they should be vaccinated. And this can be administered simultaneously with the inactivated influenza vaccine. Otherwise, an opportunity to vaccinate might be missed. Antibody levels were also looked at for the 3 influenza subtypes. It was a trivalent vaccine that was studied. It was studied in adults 50 years of age and older. Here it was kind of a reverse situation from the PCV13 antibodies. And so basically in those 50 through 64, there was the antibody level rise was fine. Only among patients 65 years old and older were there reduced antibody levels, and only to H3N2. However, the criteria for defining immunogenicity is a little complicated for influenza. When you're talking about the rise in antibody level in someone who may previously have been exposed to influenza in the past with disease or prior vaccination, it can be very complicated to correlate what you're seeing with risk, with the way the vaccine works. And so we do make the recommendation in these patients 65 years old and older, the risk for complications of influenza are very high. You don't want to miss an opportunity to vaccinate, and so you do need to give the vaccine simultaneously.
Okay, thank you. So I think you covered this, but I think it bears repeating. What if an adult already received both PCV13 and PPSV23 at the same clinic visit? They shouldn't be given simultaneously. Is there a circumstance under which you would repeat either vaccine because you erred and gave the two together?
No, in this circumstance, you do not need to repeat either dose of vaccine. I will make a note that if this occurred in an adult younger than 65 years of age, this is not really a repeat dose, of course. This is just the routinely recommended dose they would need of PPSV23 after the 65th birthday. You would still give that dose, but no, you do not need to repeat these doses. It shouldn't have been done, but we have no data that say a repeat dose should be given, and so we don't recommend it.
Okay. We just received a question saying, well, let's go to the other extreme. If you've got a 6-month-old child and it's influenza season, as it is now really, and the child is there for the 6-month visit, is due for a number of vaccines, one of which is PCV13, is it acceptable to give influenza vaccine to that child and the PCV13 dose?
Yes, both vaccines are recommended and both should be given. We know that there may be risks of fever that are slightly elevated in a child that receives both vaccine doses at the same time. That is true. But we also know that risks of severe disease that can involve fevers are very possible if vaccine is missed. And so we don't want diseases occurring in these children with fevers or without. So we do recommend the vaccination. With fever can sometimes occur febrile seizures, and we have seen a slightly increased risk of febrile seizures when PCV 13 has been administered with, this happened in 1 year in 2010 with IIV. We noticed it, or it happened with one type of influenza vaccine. I think it might have happened in a subsequent year as well, but it was with the same vaccine type and has not been seen since. With simultaneous vaccination, we saw an increase, one excess febrile seizure for every 2,600 doses of simultaneous vaccination, an extremely small risk outweighed by kind of risks of missing opportunities to vaccinate. And if there is a child that, has a history of febrile seizures and there's this concern, it's important we tell providers to ask about whether this history exists and to make the patient and their parents aware of the existence of antipyretics, which can be used if a fever occurs following vaccine dosing.
Okay, so we'll swing to the other end of the age spectrum. And again, to confirm, I think the information you already gave, but we've been asked to repeat it. In a pneumococcal vaccine naive adult who is 65 years of age or older, is there any circumstance under which that adult, regardless of health status, would receive more than one dose of PCV13 or PPSV23?
Generally, no. In almost every circumstance, no. The routine recommendation is for PCV13 for adults 65 years of age and older, and PPSV23. PCV13 should be given first. It has demonstrated effectiveness against pneumococcal pneumonia. So that probably, I didn't mention that, but that probably is the most important reason for choosing that vaccine first in this circumstance. And then PPSV23 would be given a year later. The one rare circumstance, and I'm not even sure how often that might occur, is previous vaccination followed by a bone marrow transplant or something involves a slightly different post bone marrow transplant regimen that involves multiple doses of PCV13, driven, of course, by the risk of invasive disease in patients post bone marrow transplant. But that's a very rare case. And so in general, we're talking one dose of PCV13 and one dose of PPSV23, PCV13 first, and a year between them.
Okay, so we received a question asking for a little more clarification about why are cochlear implants, people having cochlear implants, at increased risk for invasive pneumococcal disease.
There was a case series reported, I believe, in the early part of the 2000s on bacterial meningitis in patients that had received cochlear implants, and the predominant organism that was recovered in the taps was Streptococcus pneumoniae. So patients with the idea being that patients with cochlear implants, they have a device that's surgically implanted. It transmits auditory signals from the cochlea to the brain artificially. That's why the device is used. I think they're about, the numbers have grown since the early 2000s. I think it's gone from 10,000 to 30,000 patients have this type of device. You can see, that they might be at an increased risk for this disease. And in fact, the case series kind of demonstrated that they are. I think it might have been studied a little more elaborately than that too, beyond the case series. But we deem this a risk, and they should receive pneumococcal conjugate vaccine, as well as the polysaccharide vaccine, outside of routinely recommended ages. And we don't recommend the repeat dose of the polysaccharide vaccine at the 5-year interval, of course. But we do have special recommendations for this vaccine because of that.
Thank you very much, and we'll try to find the relevant references and post them on the website. I think one additional point that to make is that you have then basically created a pathway between the outside world and entrance to the brain, and therefore, even though it's supposed to be closed by the cochlear implant, there apparently is a risk, because people have increased risk of these infections for passageway by viruses and bacteria. And hence the increased risk. At least we think that's part of the explanation. Last question before we close up and finish with additional CE information. A clinic writes in saying, we've only got pneumococcal polysaccharide vaccine available right now for a while, and should we be giving our older patients or other high-risk patients that vaccine first, or should we wait some period of time to give PCV13 first? How long should we wait?
Ooh, that's a tough question. We don't want you to miss an opportunity to vaccinate with the vaccine that you have, but just keep in mind that if PPSV23 is administered first, we need to you're going to have to wait a year before PCV13 can be administered. So I guess, I mean, the advice would be, don't miss opportunity to vaccinate, but try to preempt this by determining where PCV13 might be available in your community. If you can help the patients out and obtain that vaccine or make a reference to get PCV13, we really want PCV13 to be given first, just because it preempts the need to have a year-long wait between the two doses of vaccine, and both vaccines are needed, but we don't recommend them simultaneously.
Okay, thank you very much. That's our last question we can address during the live program. Again, we'll have written answers to these questions and the ones we did not get to posted on the Pink Book webinar resources page. Please look for those as well as the slides, the transcript, and other parts of the program. Let me wrap up by giving you the continuing education information again. For CE credit, please go to http://www.2a.cdc.gov/TCE online. The live event course number is WC2645-092116. That's WC2645- today's date, 092116. CE credit for the live program expires October 24th, 2016. The Enduring Archive course number is WD as in David, 2645- again, today's date, 092116. CE credit for the Enduring program expires June 1, 2018. The verification code for both programs is PNEUMO, capital PNEUMO-16. For help with the online CE system, if you have difficulty, please call 1-800-41-TRAIN, or you can email us at ce@cdc.gov. If you have immunization questions from this seminar or anything else at all, and if it's from this seminar, please indicate it's from today's seminar. Otherwise, just indicate in the subject line what you're looking for to nipinfo@cdc.gov. If you need to call us, you can call us at 1-800-CDC-INFO on your phone pad between 8 a.m. and 8 p.m. Eastern Time, Monday through Friday. And additional resources are the Pink Book, which website you see there, our vaccine immunization homepage at cdc.gov/vaccines. And there are additional resources for you and your patients at cdc.gov vaccines/ed/downloads/imz-resources.pdf. And thank you for attending today's broadcast, the last in our series for this year. And we wish you well from Atlanta. Thank you.